learn to love eating nutritiously always. Join Lena in the fight against type 2 diabetes. Visit lenafood.life.
Welcome to another edition of Don't Eat Yourself to Death, sponsored by LLENA, and we are just here today with my partner, Charlotta Carter, and we're talking to Dr. Bryan Batch, a physician and endocrinologist, and she is going to bring us some different exciting perspectives concerning diabetes, some of its effects, and ways that we can fight this thing called diabetes. And now I shift over to my host, Charlotta Carter. Charlotta?
Thank you so much, Rinaldi. And thank you, Dr. Bash, for being here. I know you've been very supportive of what we're doing. We're like minds on how to approach diabetes and how to care for it. And it's definitely our strategy at LLENA to do so. So thank you so much for your time. I know you're super busy, and I'm going to turn it over to you to tell us the wonderful things that you're doing and your background so that our audience will know that they're getting some really good information from the medical community.
Thank you so much for having me. It's been a pleasure working with you and just really exploring how we can eat better and live better lives and live healthier. I'm an endocrinologist, and I went to UNC for medical school, University of North Carolina, here in Chapel Hill in beautiful North Carolina, and then did my endocrine fellowship at Duke University, and then stayed on at Duke, and I'm here as an associate professor at Duke University, and also work at the Durham VA. I have a passion for helping people to live healthier, and I chose endocrinology because I really love the idea that I live and work with someone and partner with them through their lifespan, from the time that they are young with diabetes until the time that they're older with diabetes. I really enjoy getting to know my patients and really helping them through many of the challenges that they face with diabetes. I had many family members who had diabetes, and it's one of the things that I think really encouraged me to become a doctor, to become a physician. And I watched my parents, who were also physicians, really partner with their patients in their own specialties. And so that's how I got my start. I spend every day thinking about how I can help people to change their behavior and to change their lifestyle. I don't like the idea of diets. I don't like the idea of not recognizing the individual power we have as people to make a change for the better. And the incredible part of it to me is that most of what I tell people to do, or I suggest to people to do, and I partner with them to do, is free. Okay, these are not things that cost a lot of money, changing our behavior, but it's difficult. And so I really enjoy sitting with people and helping them through that struggle of figuring out how to live healthier.
When you are starting out, I would say, let's just take your patients that are children. How do you approach, working with children opposed to how you approach working with adults? Are you seeing a difference in when you're working with children and following them into, teens and things like that, to see that, the recommendations are helping?
Yeah, that's a good question. So I'm an adult endocrinologist, so I typically take care of patients who are older than 18, but we work really closely with pediatric endocrinologists because, of course, as you have already alluded to, we have more children developing diabetes at younger ages and then transitioning into adulthood. Diabetes is always a team sport. It always takes many people. So for our kids and for adolescents in particular, their parents are usually very involved, as are their schools and their teachers, their coaches, their extended family. But even into adulthood, we have patients who rely on their family, who rely sometimes on their children, their grown children, who rely on their spouses, significant others, church family. So I always think about diabetes as a team sport. I think one of the most important aspects of diabetes at all ages, but particularly for children, is really fostering a good and healthy relationship with food. And by that, I mean really starting at a young age, teaching children about food, nutrition facts, and how they can have a healthy diet that can then foster better diabetes control. We have not done a good job of that as a country in the United States. We focused a lot in the decades before now on fat and salt without a real focus on carbohydrates or on glycemic index. And so that, I think, is probably one of the most powerful things that we can do for young people but also for older generations, is to really talk about nutrition and to understand what we're eating and what we're exposing our bodies to. And the second piece of that is physical activity. People really underestimate the power of walking, the power of being physically active. We've seen in the last year with COVID in particular that there's been a significant decrease in activity and a significant worsening of diet. And that combination has led to worsening overall for many of my patients in the last year. And so I'm having to reteach and to re-engage people in these lessons about diet and physical activity. But I'd say those are the biggest things.
You touched on the glycemic index. Talk to us a little bit, because our LLENA approach is about glycemic index and glycemic load. So talk a little bit about why that's important and the difference between the glycemic index and glycemic loads, that and how it applies to, to managing diabetes.
Excellent question. So one of the things that I try very early on in education about diabetes with patients, I try to focus on the fact that the most important aspect of diet that raises diabetes is carbohydrates or sugar, okay, period. And people don't really think about carbohydrates or sugar in sort of in a vacuum, right? And that's not how we build our diets typically either. So glycemic index is really about how much your blood sugar is raised by what you eat. And it's standardized based on sugar as an element. And so you can go to many websites, you can use some technology. LLENA is a good example of the type of technology that can help people understand this better. But you can understand before you eat a piece of food what the glycemic index is. And it really is a good correlate to how it's going to affect your blood sugar. But again, most people don't eat sugar in and of itself on its own. Most food is not built that way. We eat meals. So we eat in the context of meals. And so the concept of glycemic load is really about those mixed meals, about fat and carbohydrate and sodium and salt, things like that, and how they come together to really affect blood sugar. The great example of glycemic load and the difference between glycemic index and glycemic load is a food like pizza, where you have a significant amount of carbohydrate or starch in the base of the pizza, but you have fat in the form of cheese on the pizza, and then you have many other components. And so that is typically a difficult food to account for patients with diabetes. But really important to understand, when you really break it down, it's not rocket science. It's really about having the tools, I think, to help individuals understand how to manage when they're going to look at what to eat on a daily basis.
Because I can almost wrap my French fries in spinach and I'll be okay.
Right. Well, it's also about portion, and that's actually what gets people in trouble sometimes, because in this country we have very calorie dense food that's small. You can eat something very small that has a lot of calories and a lot of starch and a lot of fat. And so again, this idea of nutrition education, I think, is so critically important. And people sometimes will say to me, I have patients that say, I'm not good with numbers. I have many patients who didn't go very far in school. And so they equate, they sort of think about their book smarts with their ability. And I always tell people that is not true. Dash that. When you come in the door with me, it's about starting from where you are. So if you're not a numbers person, I was never a numbers person growing up. That's why I'm not a physicist. Then it's about really helping people to have the tools and strategies to really understand how to make better choices.
Well, and I think that, one of the things, because my journey really, when I got diagnosed and I was on insulin, right? And so, during the 6 months that I went through the whole program with watching my glycemic index intake and managing and exercise and coaching, it was really very daunting. So it wasn't necessarily the numbers as it was, okay, what's my number today? What's my number now? Got to go look and see what glycemic index and glycemic load I can use, and back and forth, what can I cook if I'm traveling? So
that's right.
that was the really hard part for me, which really drove us to, to develop this platform, because I felt if it was difficult for me as a technologist, I mean,
Yep.
gotta be difficult for, everybody else that's out there, that's not in this technological world. So
That's right.
I totally understand that it's diet, exercise, and coaching all sounds really easy, right? And sometimes it's really easy to start, but it's not easy to continue sometimes. So
That's right. That's right. Hit something I think that's really important too, which is, if you can tolerate eating boxed meals, then someone will calculate it for you. But that's not the way that we live as human beings typically. And it doesn't take into account our own culture, the piece of us that is who we are, that home cooked meal, that feeling of family where there are no numbers attached. I don't know how much carb and salt and sugars in my grandmother's ratatouille or in her gumbo. I don't know. And I can't pay a company to figure it out. And some I may not want to know. So yeah, it's about being able to fit in people's life. So that's important. That's
The
important.
importance of making LENA very easy and simple is, as Charlotta said, is the reason we, come together and make it easy for people. If it's easy, they'll do it. If it's hard, they won't. And
That's right.
that's just human nature. Dr. Batch,
Yeah.
what are some of the effects on, say, thyroids? And because we know diabetes affects, as you say, individuals different ways. And so what are some of the things that we can focus in on lipids and on thyroids?
Yeah, so it's an excellent question. So the first thing that I'll say is that there are different types of diabetes, and we're learning a lot more about the different types of diabetes, but also the overlap. For some patients, there's a very significant autoimmune component, meaning that the cause of their diabetes is related to the development of what are called antibodies, things that are in the blood that circulate, that go to the pancreas, the organ that makes insulin, and they kill the pancreas, or they make the pancreas work less well. And so for patients that have autoimmune background to their diabetes, thyroid disease is also very common. So thyroid disease and diabetes can go hand in hand for many patients that have that kind of autoimmune background in their history, personally, or in their family. Lipids, so cholesterol control, is actually so critically important in diabetes because we know that patients with diabetes are more at risk for heart disease, and reducing or lowering the bad cholesterol in particular, called the LDL, is what helps reduce people's risk of developing heart disease and stroke down the line. Okay. We also know that it has negative effects, that cholesterol and elevated cholesterol can have negative effects on vascular disease as well, or blood flow, specifically to the legs. And so there's increased risk for things like amputation in diabetes, for what's called neuropathy or nerve damage in diabetes. So sugar control and cholesterol control go hand in hand.
How much of an effect do the drugs that work to control cholesterol, like statins, how much of because every bottle you pick up has a side effect or several side effects.
Absolutely.
How are those balanced off in medication that people take for diabetes?
Yeah, so one of the interesting things that we've learned over time about the statin drugs, because those are the most commonly used, is that they can actually raise blood sugar by about 5%. So statins can raise blood sugar. And it's not usually a problem for patients that already have diabetes, but for people who are on the edge, who have what's called pre-diabetes, sometimes a statin can increase sugars enough that you can see people go from having pre-diabetes to diabetes. But what I'll tell you is that the risk reduction, the lowering of risk for heart disease and stroke with the statin medications is so tremendous that it nearly obliterates the risk of increased blood sugars with statin drugs, meaning that the positive effects of statin drugs on reduction in risk outweigh the negative of maybe having a little bit of a higher blood sugar. Now, we're talking about food a lot today, and what people don't recognize is changing your diet can dramatically lower your cholesterol. Okay, so again, the power of behavior and food, and then I'll throw exercise in, of course, can lower cholesterol And so for young patients that are less than 40 who have high cholesterol, they have a lot of power in what they do in terms of weight loss, diet, and exercise to be able to lower their cholesterol enough so that sometimes they don't need medication for their cholesterol. Now, of course, there are some patients who are different. Their cholesterol is incredibly high. They have a family history of heart disease before the age of 40. They're a different group. But for the general person, for the 30-year-old who's overweight, who has high cholesterol, hasn't quite, developed diabetes, weight loss, diet are huge. They are everything for lowering risk of progressing to having worse disease, if that makes sense.
We're going to take a break, and we're going to come back with our special guest, Dr. Bryan Batch and Charlotta Carter, and I'm Rinaldi Jacobs, and you're listening to Don't Eat Yourself to Death.
Learn to love eating nutritiously always. Join LLENA in the fight against type 2 diabetes. Visit lenafood.life.
Welcome back to Don't Eat Yourself to Death with Charlotta Carter and Rinaldi Jacobs, and our very special guest, Dr. Bryan Batch, who is an endocrinologist, and she's really giving us some great information about the effects of diabetes.
And Dr. Batch, we were getting into a conversation about diabetes and kidney failure, and we were really concerned about why does that seem to be a natural progression if you've got diabetes. We see so many dialysis clinics in our communities, and we see just people having kidney failure when they've contracted or been diagnosed with diabetes. Is it the lifestyle, the diabetes itself? Is it the pharmaceuticals we're taking? What can we glean from that situation?
This is such an excellent question. And as doctors, we get focused very often on the things that we're interested in, like blood pressure and what your actual blood sugars are and other things. But what patients are focused on is, how can I prevent dialysis?
Mm-hmm.
How can I prevent amputation? How can I prevent heart attack, stroke? The patient-centered outcomes that really matter to people every single day, and blindness, I'll put in there. Kidney disease is usually, in most diabetes patients, what we call multifactorial. So their diabetes can be the big driver of that. And high blood sugars set up an inflammatory process that affects the glomeruli and parts of the kidney that help with filtering, okay? So blood sugars and high blood sugars alone are a big part of progression of diabetes, which is why we work so hard to try to get patients to have better blood sugar control, because high blood sugars set up this inflammatory process that affects the kidney. But the other thing that we see very often, almost go hand in hand with every patient, is high blood pressure. And uncontrolled blood pressure, so hypertension, we call it, the scientific name for it, can also have extremely significant and negative effects on the kidney, on those smaller parts of the kidney, the smaller blood vessels in the kidney, which help with filtration. So you have high blood sugars with blood pressure that's uncontrolled, but also you have then high cholesterol that comes in as well. And so those three things just set up a situation where the kidney starts to fail over time. And sometimes it's a slow process. For some people, it can be decades. For some people, it's a very, very quick process, and they go from having, abnormal kidney disease to basically going to dialysis in the course of a very short period of time. The other thing that we are learning more and more about is that obesity, so being obese or overweight, also fuels this inflammatory process and these inflammatory mediators that then go and affect the kidney directly. So that whole entire situation, high blood sugars, high blood pressure, high cholesterol, and obesity or overweight, all affect the kidney directly. And the one thing that is not recognized by patients is that catching your diabetes early on, right? So screening for diabetes and recognizing you have diabetes early on can actually prevent this type of progression to kidney disease. And so often what we see in our community, in the Black community, is patients are getting diagnosed with diabetes late. They're not coming in and their A1C is 6.7. They're coming in and their hemoglobin A1C is 14 and their blood sugars at presentation were 900 or 1,000. And so when you see patients in that situation, they've had high blood sugars for a long time, a long time. And that time frame, during that time frame, their kidneys been suffering, their eyes have been suffering, a heart has been suffering. This inflammatory process that's set up is essentially been allowed to run amok for many, many months and sometimes even years. And so recognizing early on what you need to do to screen, or whether you're at risk, and sometimes that's family history, but being overweight and aging is enough to put up some risk factors to, encourage your doctor to screen. But those things, I think, are why we see kidney disease so frequently. And the reason why it affects the Black community, again, sometimes is this delay in diagnosis, but there are also things that we don't understand about diabetes still that are being researched and followed with regard to the worsening, kind of what we see as the elevated risk and elevated prevalence of kidney disease in the Black community. But hypertension is one of those things that drives it. So uncontrolled blood pressure, for sure.
Is there a correlation between pancreatic cancer and diabetes as well, too?
Mm-hmm.
Pancreatic cancer is one of those they call unlucky diseases, because you don't know you have it until it's, too late.
That's right. That's right.
Yeah. But is there a correlation between diabetes and pancreatic cancer?
There is a correlation. And so sometimes what will happen is people will get diagnosed with pancreatic cancer because they come in with uncontrolled diabetes. And their blood sugars are elevated and no one really kind of clearly knows why. And another thing that we see occasionally is patients that have diabetes and it's been well controlled, and all of a sudden it just takes off. So, you're on metformin or some other medication and you're doing fine. And then all of a sudden you rapidly progress to needing insulin. So, there is a correlation, but we also see patients with pancreatic cancer that don't have diabetes as well. Okay. The pancreas is an interesting organ. It's long. It's kind of like a long rectangle with a tail, or is shaped like a long rectangle with a tail. And there's the head of the pancreas and there's the tail of the pancreas, and different parts of the pancreas make insulin, but there are other parts of the pancreas that make digestive enzymes, what we need to basically digest our food. And so depending on where your cancer is what is affected first. And clearly the treatment for pancreatic cancer, affects the entire pancreas, because typically it's surgery for most people. And so then that will create diabetes if you don't already have diabetes. It will lead to diabetes. So, yeah.
Dr. Batch, obviously certain communities suffer more. Native indigenous people, African Americans, Black and brown people have a greater suffrage in dealing with diabetes, as you say. First of all, getting diagnosed early enough. And then there's that great evil, COVID-19. There is in our communities a natural, based upon history, apprehension to a certain extent of the medical community. And of course, we saw this with the vaccine hesitation. And we know that diabetes is one of the main markers that the COVID virus looks for, those vulnerable populations. So how can we get past that using the technology like LENA, and also educate people in all communities about getting checked early for some of the early markers before you get diabetes or some of these other diseases?
Yeah, no, it's an excellent question. So COVID-19 has just exposed so many disparities with regard to health, and with regard to wellness and access. And one of the things that we know after looking at patients who present to the hospital and typically do worse with COVID is that along with diabetes is obesity. Greater than 80% of African American women in this country are overweight or obese. And so really focusing on diet and weight loss and physical activity can help reduce risk, and not just for development of diabetes, but can help improve glycemic control and can also reduce your risk with regard to COVID. Okay, so I think using technologies like LENA to help people to make better choices with regard to food, have a better awareness of foods that they're eating that can affect blood sugars, all of that is actually going to lead to better health, because people are going to lose weight and people are going to eat healthier and they're going to have less risk. And so I think that really focusing on lifestyle change is at the core of this.
Charlotta, you had some questions about preventive medicine.
Actually, yeah, I wanted to start with preventative medicine, but I wanted to start with the amount of money that we spent on type 2 diabetes healthcare costs. In 2017, 2018, we spent, the US alone, spent over $270 billion in type 2 diabetes healthcare costs. And I'm wondering if we utilize more preventative medicine approaches in our healthcare system, if we could drive that number down, if we had better education, if we would allow our patients to come in on a yearly or 6 month basis, opposed to waiting until their diabetes is out of control, or they're losing their sight, or losing a limb. What do you think about preventative medicine, Dr. Batch, and how could we do better? I know the Canadian system is that way. What about the US system on the preventative medicine side?
Yeah, I think that one of the most challenging aspects of my job every day is knowing and acknowledging that diabetes is preventable. Now, there are some patients, and we talked about this earlier, who have an autoimmune background to their diabetes, but for the most part, it's driven so much by obesity, and obesity is a background. And even in the early stages of obesity, when patients' blood sugars are starting to creep up a little bit, we can catch them in the prediabetes range by doing simple tests like A1C that can prevent them from moving on to diabetes. And so I, really try to encourage primary care doctors when I do in services, when people come and ask me to speak. And a lot of times they'll say, "Oh, can you come and speak about the medications?" I always say, I'm happy to speak about the medications, but I really want to talk about prevention. Because by the time patients get to me, they're far gone. They're beyond the point where I can be the most helpful to them. They typically are going to require multiple medications for therapy, which is going to cause them to gain weight. And there's a risk of hypoglycemia. So preventing people from even getting to diabetes is of paramount importance. And again, there are simple screening tests we can do, to discover diabetes early.
One of the threads of all of our discussions about diabetes, that word obesity keeps coming up over and over and over again. And I'm wondering if it's like the Supreme Court justice said about pornography, you know it when you see it. But I think with obesity, we don't necessarily know it when we see it. So, how does that fit for different body sizes, different cultural differences? How does obesity, some people we may think are not obese are, and perhaps some that we think are obese perhaps are not. So, what are some of the, is it the body mass index? What are some of the things that help us to define the obesity situation that can get us into trouble with diabetes?
Right. So that's a great question. I think when you think about obesity, really what we're referring to in this country is body mass index, which essentially is a way of looking at people's weight for their height. So it's a way to compare someone like me, I'm 5'3", to someone who might be a woman who is a different build who might be 5'8". Okay, someone who's 5'8" should not weigh the same as I do. So it's kind of a way of normalizing. But what we've recognized over time is that BMI is not a good measure for every type of race and ethnic group. Asian populations, for example, their BMI is typically their risk for obesity, their risk for diabetes, and the measure of obesity is actually lower. So it's at a lower BMI. We also recognize that for Black populations, BMI doesn't always correlate with health. So you'll see patients who have a BMI of 30 and they don't have diabetes, and they don't have high blood pressure, and they don't have heart disease. And so you think to yourself, well, what are the goals, right? How do we normalize the goals? How do we figure out what that person should be doing? Do they really need to lose weight? So BMI is a really complicated measure. What I tell people is to think about themselves in context. So it's not just about your weight, it's also about your numbers. So knowing your A1C, knowing your cholesterol, knowing your family history and your personal history is really important.
We're looking at COVID and how we've sort of had to weave into telemedicine. Has that been a blessing or a curse for the diabetic sufferers? So has it been better that you can reach your doctor by phone or email or Zoom? Has it been a blessing or a curse, or what have you seen over the last year?
Yeah, yeah. This is something I've been thinking so much about. I spend a lot of my time thinking about this because in some ways access is better, but not for everyone. For those individuals who don't have access to the internet, that don't have access to a phone that has unlimited data, their access really hasn't improved. In fact, I think most hospital systems have really pushed video visits, and those are patients who might benefit from telephone. So we've done a good job with trying to increase access. We have not done a good job of making sure that access has been equitably increased amongst every population. Okay. The second thing is that for my patients who are established, who I know well, and if they have access to data, if they can send me their blood sugars, then I can do a really good job with virtual care, actually. It's patients who I don't know as well, where I haven't established that personal relationship. It's hard to connect over phone or sometimes even video, where I feel that personal touch and interaction is missing, which helps create a team bond around doing better in terms of diabetes. And also, those are patients that typically don't have access to technology. And so I have a lack of understanding, usually a lack of data around how their blood sugar is doing, what their trends are, potentially what they're eating. And so then you can be in a little bit of a data desert, which makes it more difficult to manage diabetes, actually. So, if it were the best of worlds and everyone had unlimited access to internet, knew how to use technology, had the technology that was required, then video visits would be, I think, an equitable way of delivering care to everyone. But that's not the reality in this country.
Given the reality of that, how important, I need my teenage grandkids to program the remote. So,
Yeah.
but how important is it for family, especially older folks who may not be as familiar with the technology?
Yeah.
Talk a little bit about the inclusiveness of family members helping with things like, you can't eat that. No, put that down. You can't have that. Plus all those things, because in many cases, we're all doing different prepared foods and things like that, Char. And you and I are always exchanging recipes. But talk about the importance of the connectiveness of having family around you and how that can play an important role in using programs like LENA and telemedicine.
Yeah, family is everything. And I've really, I've always appreciated when family comes to appointments and when they're involved, but especially with technology where someone's not as facile, it's really important. We can do video visits that are groups where we have children. I have patients who have their kids from across the country dial in, and there are younger kids who come, their spouses who can't be there physically or in person. So that's been huge and actually really incredibly helpful. But you're right, we need to have, again, the team. It needs to be the village and the team helping. And technology should not be used because someone isn't experienced in using it. We need to be able to bring other people into the fold that can help people use the technology that has advanced diabetes care so much.
I'm going to ask one more techie question, and that's around CGMs. So
Yep.
I wear CGM. I know that there are different ones for different types.
Yep.
There is a new device coming out, a company partnering with Apple, and they're using the Apple Watch to actually give the blood pressure, blood sugar, which we're really excited about, because once into eye health, we get to get it into our system immediately.
Yeah.
Do you have patients that use it? Are they anticipating it? Can you get them to use it? What's been the adaptation of those types of devices in managing diabetes?
Yeah, so people that are listening, CGMs are continuous glucose monitors, and they essentially measure blood sugar in what's called the interstitial fluid, so the fluid between the fat cells. So you can wear a sensor on your body, it measures your blood sugar every 5 minutes, and then it can transmit that data to your phone or to a reader or another device, and they're incredible devices. We have seen a tremendous uptake of the use of these devices in our patient population. We've been delighted as endocrinologists to have the data, to have access to not just blood sugars when people prick their finger, but blood sugars during the entire day. And actually, we learn a lot about those trends. We learn a tremendous about blood sugars overnight, which we typically didn't have access to. And I'll tell you, patients learn a lot about what they eat and how it affects their blood sugars. And it's been an incredible educational tool. A strategy that I use, I pull up the data with my patients in the room and I say, hey, what'd you eat? What'd you eat after dinner last night? You know, and it's been really instrumental. And I've seen people drop their A1C by 2 and 3 and 4% with just that information. They're not for everyone. You know, everyone doesn't want to have to wear a device, and they're not for people who don't need to check their blood sugars very frequently. So if you're on metformin once a day, you may not need a continuous glucose monitor unless you really need to understand your trends. And for some people, that's true. But if you're doing well and you have a good handle on your diet and you're exercising like you need to, then it's probably overkill to use this kind of device. But yeah, they've been hugely useful for patients and providers. And it's a really great way, I find, to really partner with patients around what's actually happening in real time. So yeah, we've been excited about the development.
So let's talk a little bit about targeted eating and targeted access to food. Now, of course, COVID has changed the whole world. You can order your stuff from Walmart, but that doesn't mean you know what to order. And
Absolutely.
LENA, of course, LENA's and Charlotta, you can expand a little bit how LENA is really working to make sure that we can have SNAP beneficiaries involved. In other words, the most vulnerable, who have the least technology and who have the least but have the worst outcomes. So,
That's
Doc,
right.
why don't you talk a little bit about how our food and the education about our food. For example, I have a very close friend who has diabetes. You would think grapes are healthy. You know, it's
Goodness.
grapes. Yeah, exactly.
Sugar bomb.
Exactly.
Sugar bomb. Yeah.
But see, as a person who does not have diabetes, I wouldn't understand that. I would think certain fruits are, you know, the fruit cocktail. Hey, man, it's fruit. But those things are really not good for diabetics. So talk a little bit about how we can educate not only the patient, but educate ourselves about food access and lack of food access for certain communities and how we can improve those outcomes.
Yeah, so I think in terms of food access, I think, you know, the companies want us to think that gluten-free organic is the only thing that will keep you healthy. But the truth of the matter is educating yourself about nutrition is the thing that's going to keep you healthy. And you can do a lot with less money if you know what to look for. So learning how to read a nutrition fact label is everything, everything. And if you have technology, if you have a smartphone, downloading it, some type of software or an app that can help you further understand what to choose is incredibly important, period, end of story. Because most of us are a bit lazy, right? And you want to go to the grocery store and you want to buy your food. You don't want to be there for 2 hours trying to read every label. So having technology to help you with that is incredibly useful. But it doesn't have to be organic. It certainly doesn't have to be gluten-free. It just has to be low carb, right? And one of the things that people forget, I remember growing up, you'd go in the grocery store, there was raw stuff and there was frozen stuff. And there was a few things in the frozen section that were cooked that didn't really taste that good. Frozen foods, particularly vegetables, can be incredibly good for you, okay? You can eat foods out of a can that are reasonably good if you know how to prepare them well. You can eat reasonable meats that are healthy for diabetes if they're not covered in flour and fried, right? So there are some simple things you can do. There are better fruits than others, but most of us need to have education around what to look for and what to buy. And it takes time and it takes effort, and it's not easy. But once people learn it and it becomes a part of their lifestyle, then they'll never forget it.
Dr. Batch, let's go to the box reading, okay?
Yeah,
And I think I'm a fairly educated guy. I have 2 college degrees, but I swear to goodness, when I look at the box, I'm like, what the heck is, blah, blah, blah,
yeah,
So for me as a heart patient, it's the sodium. And I think
right.
to Charlotta's point, a lot of our food has marketing attached to it,
That's
just like
right.
medicines are being marketed. And for example, I went into a popular big box store. I won't call out the name of Walmart, but I'm looking at different chicken broths, and the one that said low sodium. So I said, okay. So I compared that to, the other one that wasn't low, and the one that was low sodium by the label had the same amount of sodium as the other
Right,
one. So
right, right.
I think the education of the consumer in terms of what is corn syrup versus
Yep.
this and versus that, and I'll bring a personal part to this. My grandson, my wife and I kept telling my son and my daughter-in-law, listen, it's easy to give the kids the little juicy juices, Char, and I know you have grandkids and stuff like that.
Hmm.
Until her doctor told her, the kid needs to drink more water. And we bought him a little Happy Meal once, and they had the apple juice in it. And that kid went after that like, oh my God, juice.
Yeah.
I get something like that, something fun. But talk a little bit about how it's important for people to understand the back of those labels and how Lena and other programs, Charlotta, can really help them get past that.
Yeah, I tell people, forget the pictures, forget all of the garbage on the front that tries to catch your attention, and also be aware of the end of the aisles and areas where they like to entice you with the garbage food like chips and salsa and dip and cookies, and turn directly to the nutrition facts label, because that's where the information is. That's where the companies by law cannot lie to you about what's in that box or in that can or in that jar. Okay. And if you can't know or understand how to do it, then download an app like LLENA, download other apps where you can actually scan the barcodes and it'll tell you if it's a good or a bad choice for you. Okay. And acknowledge, I think people need to acknowledge what they need. If you know, be real and be honest. If you know that you're not going to read the label and you're going to be lazy about it, or if you know that you don't really understand it, then find the tool that's going to help you tear down that barrier, the barrier of not feeling like doing it, the barrier of not understanding how to do it. And if you don't have technology, then get a friend or a family member to help you. Okay. But you have to do the work.
COVID is making us prepare more scratch, as we used to say, from scratch now. People are trying
Yeah.
more things in terms of their own food prep. How, Charlotta, and I know that you're a semi chef and your sister's a chef, how are home cooked meals, are they better, Dr. Batch, if we prepare them ourselves, versus the processed food, as my wife calls it? Stop bringing all that processed stuff home. But,
Okay.
and, like fresh versus canned. For me, it's always fresh because there's so much sodium, but there's
Yeah.
also a lot of sugars in things. How much better can we do, ladies, in preparing home cooked meals
Mhm.
as opposed to just add water, put in microwave 3 minutes, and
Yeah.
it's done?
Charlotte, I'll let you speak to that first.
Home cooked meals are by far, what's in it type of
Yep.
thing. What we do with the customized recipes that we give out, we have all of that information on all the ingredients that are in there. And we utilize artificial intelligence as well as the values that are provided through the USDA database. We also utilize glycemic index databases. So we utilize a number of different technologies to cross-reference a lot of those recipes that are in there to give you a highlight of what's red, yellow, and green. So, if you've got a really high blood sugar, you're going to look for something that's really low in glycemic index.
That's right.
And vice versa, if if your blood sugars are like 2 or 3, you're going to have to eat something fairly quickly to kind of balance you out a little bit. So
Yeah.
we definitely, for the home cooked meals or the ones that we recommend, utilize the labeling information, USDA, glycemic index values. We utilize all of that to really make that customized recommendation for you. So cooking at home is a lot better. You don't know what the chef at some your favorite restaurants putting there, how much sugar, how much salt, how much oil, how much grease, how much butter. You have no idea. So we are going to try to work on that piece of it because we do take a baseline information on some of the restaurant items. And the ones that we know that have a baseline that we can compare to our database will give you, a sample of what it should be if it's not ladle and butter and everything else. So like a chicken salad or something like that, we'll be able to give you that information without you pouring in 2 cups of dressing on it. So those are some of the things that we can help you with to kind of make those choices because you're tired or you're, just don't feel like dealing with it. So definitely, Dr. Batch, that's really our strategy. And it's coming from a place of, what top endocrinologists are always saying, nutrition, exercise, and coaching. And that's
right.
Or certain sugars, and I'm very, very cautious of marketing. For example, they'll say, oh, this is raw sugar versus regular white sugar, or use of honey. I found honey is very, is a serious sweetener. I mean, sometimes it's sweeter than sugar. Now, are those things?
It sends my blood sugar straight to the moon. So
Right.
I think sugar is sugar is sugar.
Yeah,
if you whatever, people have knockdown dragouts about this honey versus raw sugar, white sugar. It's all sugar.
Yeah.
So the focus should be on trying to reduce the amount of all of those in your diet, use them sparingly. So,
and what about things like brown rice versus regular rice? Is it the same? And then now, Char, we have the cauliflower rice. So are all these things, and I think to a certain extent, consumers get confused, about this versus that. So talk a little bit about how these labels of healthier and not necessarily the organic stuff, that's in and of itself a different discussion. But how are different aspects of products that are labeled as, I know here in Louisiana, for example, they can't label cauliflower rice as rice because they say it's not. Of course, we eat a lot of rice here in Louisiana. So talk a little bit about how some of these named categories of foods could affect it and affect how our glycemic index and all the rest of the things that we do.
Again, I go back to nutrition education. If you know how to read a label, it doesn't matter what they call it, because you're going to look on the back and you're going to see cauliflower rice is not rice, it's cauliflower. It's going to have less carb, right? And brown rice theoretically is better because it has more fiber, but it's still rice and it's still going to raise your blood sugar. So, if you know the grams of carbohydrate that are in a food, you can make a better choice of what you want your side to be with your meat or your vegetable. And if you use a technology like LLENA or others that make it even easier because they give you a green, yellow, red zone, then you can really make a better and a healthier choice. But you don't need anybody to give you false advertising or any advertising or any information on food other than what's in a nutrition facts label.
On the nutrition facts labels, and this is why I always get kind of like, okay, what do you mean? The serving size, of course, and portion size are entirely different. And it's like, okay, you can have 2 tablespoons and this equals so much sodium, or 2 tablespoons, and you're looking at it like, okay, who eats like that? So, how do we get into the good measure of food in terms of our intake of carbohydrates? And it could be, like you said, some foods are carbohydrate dense. So you're thinking, oh, okay, I'm just get a little bit of this or that, but it could really send your carbs way through the roof.
That's right. That's right. So you've hit upon serving size, and I think that's incredibly important. I think we have to readjust what we understand to be normal portion size in this country. People have to eat less.
Eat less and eat well. Well,
That's right.
Dr. Batch, it has been an enormous education session, and we're glad to have you on, and hopefully we'll get to have you back again later on in some of our other shows and some of our panel discussions, which we're planning a little bit later. You've been listening to and you've been watching Don't Eat Yourself to Death with our leader, Charlotta Carter of LLENA. I'm Rinaldi Jacobs, and Dr. Bryan Batch.